Hey, future nurses. Ready for clinicals or those big exams? We're diving deep into breast disorders today. It's a topic you'll see a ton on the wards, and we've got a fantastic expert with us.
Ready to get started?
Absolutely. Let's kick things off with assessment. It's the foundation of nursing care, but there's a lot more to it when it comes to breast disorders, right?
Definitely. Sensitive area, patient anxiety can be high. A systematic approach is key. And of course, we need to be pros at communication, making patients comfortable.
Makes sense. So what screening guidelines should every nursing student know?
The gold standard is yearly mammograms starting at 40, first line of defense. Now, for women in their 20s and 30s, we're talking clinical breast exams every 3 years. Then annually after they hit 40.
Got it. What about breast self-exams? I know they were a big deal, but where do they stand now?
That's a good question. While the focus on monthly exams has shifted, breast self-awareness is still huge. We want women to know their bodies, notice any changes, and feel confident reporting them. Some women might still choose to do self-exams.
So if a patient's doing self-exams, what's a role? Just a thumbs up.
Not quite. More proactive. Have them show you their technique. You can guide them, make sure they're doing it right, and address any questions or concerns they have. Early detection's key.
Absolutely. Now, what about patients who might need more frequent screenings or earlier ones than recommended?
That's where individualized risk assessment comes in. Family history of breast cancer, genetic predisposition like the BRCA gene, or a personal history of breast cancer. Those patients need to talk to their doctor about a personalized screening plan.
So maybe starting mammograms earlier, adding MRIs or ultrasounds or more frequent clinical breast exams. It's
Yeah.
tailoring the approach to their risks, right?
Exactly. Being proactive and catching things early. Now let's talk tools. We've got mammograms, x-rays to see inside the breast.
Amazing for spotting early signs of cancer that might not be felt.
Exactly. Then we have ultrasounds, which use sound waves. Really helpful to figure out if we're dealing with a fluid-filled cyst or a solid mass. Crucial distinction.
Mammograms and ultrasounds for the initial images. What if something suspicious pops up? Biopsies.
Yep. A biopsy is the only way to diagnose breast cancer, for sure. A tiny sneak peek of the tissue. We've got a few types. Fine needle aspiration uses a thin needle to collect cells. Core needle biopsy, slightly larger needle to get a tissue sample. Vacuum-assisted biopsy. A vacuum pulls in more tissue. And lastly, surgical biopsy. A portion or all of the suspicious area is removed.
Wow, lots of options. How did doctors decide which type to use?
It depends, size and location of the suspicious area, what the imaging shows, even patient preference. For a simple cyst, fine needle aspiration might be enough. A core needle biopsy might be better for a solid mass. And sometimes we go straight to surgical biopsy, especially if we need a larger sample or are worried about spreading cancer cells.
Each type has pros and cons. Choosing the right tool for the job makes sense. Before we jump into breast cancer, let's talk about some non-cancerous breast conditions.
Yeah.
They're not life-threatening, but they can cause a lot of anxiety and discomfort.
Absolutely. Benign breast disorders are super common. We need to be just as prepared to address them as we are with more serious conditions. Mastalgia is a frequent complaint.
Mastalgia. Sounds intense. What is it exactly?
Basically breast pain. A mild ache, sharp stabbing, anything. Some women experience it throughout their cycle, others occasionally.
So, if a patient comes in with mastalgia, what should we be thinking about?
We need to consider hormonal fluctuations, especially if the pain comes and goes with their cycle. Lifestyle, too, like caffeine or a bad bra. And of course, we rule out any underlying medical conditions.
Gathering information, considering different possibilities, and tailoring the approach. What about mastitis? Isn't that common in breastfeeding moms?
You're right. Mastitis is an inflammatory condition. It usually happens when bacteria, often staph, get into the breast through a crack in the nipple or a milk duct.
Ouch, that sounds painful. What are the signs?
Localized redness,
Mm-hmm.
warmth, tenderness, swelling, and often a fever.
Definitely not fun. What's the go-to treatment?
If caught early, mastitis responds well to antibiotics. Important to emphasize. Finish the whole course, even if symptoms improve quickly.
What if the antibiotics don't work or the infection gets worse? What happens then?
We start worrying about a lactational breast abscess.
Okay, so what is a breast abscess?
It's a collection of pus inside the breast tissue. A painful, swollen lump, often with redness and warmth. Pretty debilitating.
So how do we treat that? More antibiotics.
They're part of it, but we also need to drain the abscess, either using ultrasound or through a surgical incision.
So it's more serious than just mastitis.
Okay.
Let's talk about fibrocystic changes. I've heard the term, but I'm not really sure what it means.
Incredibly common, especially before menopause. It's a bunch of different changes that can happen in breast tissue. Excess fibrous tissue, overgrowth of cells in the milk ducts, more ducts developing, and even cysts.
A bunch of changes, not one specific thing. Are they something to be concerned about?
Usually they're benign, not cancerous, but they can be uncomfortable. Breast pain, tenderness, and the lumpy texture can be worrisome for women.
So what can we do to help manage those symptoms?
A few things. A supportive bra can help a lot. We might suggest limiting methylxanthines.
Wait, like coffee and chocolate?
Yeah, sometimes it's worth a try, especially if symptoms are bad. Over-the-counter pain relievers like ibuprofen or acetaminophen can help. Sometimes we might even consider prescriptions like danazol or birth control pills to help regulate hormones.
Interesting. Finding what works best for each patient. Now, what about fibroadenoma? Is that similar to fibrocystic changes?
It's another common cause of benign breast lumps. A bit different, though. They're solid, rubbery, easy to move around. Little benign tumors that might be related to estrogen sensitivity.
So how do we approach a patient with a fibroadenoma?
Usually start with a clinical breast exam and imaging, maybe an ultrasound, sometimes a fine needle aspiration or core biopsy to be sure. Treatment. We might just watch and wait, or if it's causing symptoms or we aren't sure about the diagnosis, we might remove it surgically.
Makes sense. So mastalgia, mastitis, fibrocystic changes, and fibroadenomas, all these benign things that can really worry patients. Now, what about nipple discharge? That seems like something that could scare anyone.
You're right. But it's important to remember most cases are benign, not related to cancer.
That's good to hear. How can we tell the difference between benign and worrisome discharge?
We look at things like color, consistency, one or both nipples, spontaneous or only one squeezed, any associated pain or a lump. Those details help guide us.
Like a detective game, gathering clues. Now, before we move on to breast cancer, I wanted to touch on men and breast issues. We don't usually think about it, but it happens, right?
Absolutely. It's much less common than in women, but it can happen. Gynecomastia is one we see pretty often.
Gynecomastia. What was that again?
Enlargement of the male breast tissue. You might see it in newborns because of the mother's hormones, or during puberty with all those hormonal changes. Even in older men as testosterone levels go down.
So it's often a normal thing caused by hormones, but are there times when it's serious?
Definitely. Most cases are benign and resolve on their own, but we always want to rule out underlying causes, like hormone imbalances, some medications, or even liver disease.
So careful assessment and further investigation if needed. All right, that wraps up those benign breast conditions. Ready to tackle breast cancer.
Let's do it. Breast cancer is a serious topic, one every nursing student needs to understand.
Definitely. Most common malignancy in American women besides skin cancer. Second leading cause of cancer death. Those are some sobering stats. What are some of the risk factors?
There are a bunch. Family history is big,
Yep.
especially close relatives, a mom, sister, daughter with breast cancer.
Family gatherings. Time to talk about health history, not just gossip.
Right. And environmental factors, exposure to chemicals, radiation, genetics too, like BRCA1 and BRCA2 gene mutations, early periods, late menopause, and of course, age. Risk goes up after 60.
Age, genetics, family history. But it sounds like even if you do everything right, you can still get breast cancer.
That's true, unfortunately. No foolproof way to prevent it. But being aware of those risk factors and making healthy choices can help lower your risk.
And those regular screenings are crucial for catching things early.
Absolutely. Early detection is key. Now let's talk about different types of breast cancer. Non-invasive and invasive.
Okay, let's start with non-invasive. What does that even mean?
Non-invasive means the cancer cells are only in the ducts or lobules of the breast. They haven't spread. Stage 0.
So they're contained.
Yeah. The most common types are ductal carcinoma in situ, DCIS, and lobular carcinoma in situ, LCIS.
What's the difference?
DCIS is like a rebellious teenager. It's in the milk ducts, but if left untreated, it could become invasive. So we treat it aggressively, surgery, sometimes radiation.
Makes sense. What about LCIS, the good kind of breast cancer?
LCIS is different. It's not actually cancer, but it means a higher risk of invasive breast cancer in the future. A warning sign.
A red flag.
Exactly. We manage LCIS with close monitoring, sometimes meds like tamoxifen to lower the risk of developing invasive cancer. Now, invasive breast cancer, that's what most people think of.
Meaning it's spread, right?
Yeah. Invasive breast cancer has grown outside the ducts or lobules, it's in the surrounding breast tissue, and it can spread to other parts of the body, like lymph nodes or organs.
Much more serious.
Yes. And there are different types of invasive breast cancer, each with its own characteristics.
Like what?
Most common is invasive ductal carcinoma. Starts in the milk ducts and then spreads. Invasive lobular carcinoma starts in the lobules, the milk-producing glands. It tends to grow in a more scattered way.
Different origins, different growth patterns. What about inflammatory breast cancer? I've heard that one is especially aggressive.
It is. It's rare but aggressive, and often has unique symptoms. Instead of a lump, the breast might be red, swollen, warm, like an infection. The skin can get thick, dimpled, sometimes called peau d'orange, orange peel.
That's pretty distinctive.
It is. We treat it quickly and aggressively. Chemo, radiation, and surgery.
Intense. Any other rarer types we should know about?
Paget's disease of the nipple affects the skin of the nipple and areola. Redness, scaling, itching, or even bleeding. It's often linked to an underlying breast cancer, DCIS, or invasive.
So those unusual nipple changes could be a sign of something more serious.
Right. Now, how is breast cancer diagnosed? Often starts with a suspicious finding on a mammogram, or a lump the woman or her doctor feels.
If a patient finds a lump, what are some red flags?
A lump that's hard, irregular in shape, doesn't move easily, and is fixed to the skin or tissue underneath is concerning. Nipple changes, too. Discharge, inversion, or skin changes. Those should be checked out quickly.
Any unusual changes mean we need to look closer. What happens next if we find something?
Biopsy. To get a definite diagnosis, if it's cancer, we need to figure out the stage, how far it's spread.
And how do you do that?
Imaging tests, CT scans, bone scans, PT scans, to see if it's spread outside the breast. We might do a sentinel lymph node biopsy, too, to check the lymph nodes under the arm.
Gathering info to get the full picture, and then you talk about treatment.
Right. Treatment for breast cancer is different for each patient. Depends on the stage, the type of cancer, the woman's age and health, and what she wants.
No one-size-fits-all approach.
Exactly. Now, let's talk about some common treatment options.
Let's start with surgery. I know there are different types.
Yep. Breast-conserving surgery, lumpectomy. We remove just the tumor and a small margin of tissue around it, usually followed by radiation to get any leftover cancer cells.
So you remove the cancer, but save as much of the breast as possible.
Exactly. Then there's mastectomy, removing the whole breast. We might do this for larger tumors, certain types of breast cancer, or if the woman wants the whole breast removed.
I imagine that's a tough decision.
Absolutely. Very personal. It's important for women to have all the information they need to make the right choice for them.
So lumpectomy and mastectomy, what about radiation? When is that used?
Radiation uses high-energy rays to kill cancer cells, often used after a lumpectomy. To lower the risk of it coming back, can also be used after mastectomy, especially if it's spread to the lymph nodes. Helps prevent recurrence.
An extra layer of protection. What about chemo?
Chemotherapy uses drugs to kill cancer cells that might have spread. It can be given before surgery, neoadjuvant, to shrink a tumor before we remove it, or after surgery, adjuvant, to kill any remaining cancer cells.
A systemic treatment that targets rogue cancer cells.
Exactly. Now, hormone therapy.
Remind me how that works.
Some breast cancers need hormones to grow, especially estrogen. Hormone therapy blocks estrogen, cuts off their food supply.
Starves the cancer cells.
Good way to think about it. It's often used after surgery or radiation to lower the risk of it coming back, especially if the cancer is hormone receptor positive.
Okay. With all these treatments, what's our role as nurses?
Our role is huge.
Right.
More than just meds and vitals, we advocate for our patients, provide education, support, and make sure they feel heard and understood. Empower them.
Sounds like a lot.
It can be, but it's rewarding. We provide clear information about their diagnosis, treatment options, and what to expect.
Break down the complex medical stuff.
Exactly. And we address their fears, answer questions honestly, validate their emotions.
Be a steady presence, a source of support and understanding.
Absolutely. And we're not alone. We're part of a team. Oncologists, surgeons, radiation oncologists, social workers.
A team effort.
Exactly. Now let's talk about nursing interventions for breast cancer patients.
Let's start with pain. I imagine that's a big one, especially after surgery.
You're right. Pain management is a top priority. Make sure patients are as comfortable as possible.
What are some good strategies?
We have a lot of pain meds, from over-the-counter ones like acetaminophen and ibuprofen to strong prescription painkillers. We assess each patient's pain and adjust meds as needed. We can also use other methods like relaxation techniques, guided imagery, even massage. to help with the meds.
Finding what works best for each person.
Exactly. Now, those surgical drains, often put in after lumpectomy or mastectomy.
Yeah, those drains, they can be scary for patients.
They can. We explain what they're for, how they work, how to take care of them. We teach them how to empty them, measure the output, recognize infection.
Help them take care of themselves at home.
Exactly. Now, lymphedema.
Remind me what that is.
Lymphedema is swelling in the arm or hand, on the side where lymph nodes were removed or damaged. During surgery or radiation, it happens when the lymphatic system, which drains fluid, is messed up.
A traffic jam in the lymphatic system.
Good analogy. It can be really hard on patients. Pain, discomfort, limited movement.
What are early signs?
Feeling of heaviness or tightness in the arm, swelling in the fingers or hand, changes in skin texture. We need to catch it early to prevent long-term problems.
What can we do?
Teach them about compression therapy, wearing a special sleeve or bandage, gentle exercises to improve circulation, and to watch for infection and report it.
Education, lifestyle changes, monitoring.
Exactly. And every patient is different. We provide individualized care.
All right, we've talked about pain, drains, lymphedema. What about emotional support? Breast cancer is scary.
You're right. Emotional support is key. Create a safe space. Let them express their fears.
Listen, validate their feelings. Let them know it's okay to not be okay.
Exactly. Sometimes just being there is the most powerful thing you can do.
We don't have all the answers, but we can be empathetic, offer compassion, and give them hope.
Absolutely. We can connect them with support groups, therapists, counselors if they need extra help.
Be an advocate. Connect them with resources.
Exactly. Now, mammoplasty.
That's breast surgery, right? But not always for cancer.
You're right. Mammoplasty is a bunch of procedures that change the size, shape, or position of the breasts. Could be cosmetic, like breast augmentation or reduction, or reconstructive after a mastectomy.
So aesthetic and reconstructive uses.
Exactly. Let's start with breast augmentation. Increasing breast size usually involves implants, silicone or saline filled, put under the breast tissue or chest muscle.
Probably popular for women who want bigger breasts.
It is. And it can have a big impact on a woman's self-esteem. But we need to remember it's still surgery, with risks and complications.
So informed consent.
Definitely. Now, breast reduction. Removing extra breast tissue, fat, and skin makes the breasts smaller and lighter.
I imagine that helps with back pain.
It does. Can be life-changing. And of course, there's the cosmetic side, too. Many women feel better about their bodies after.
Augmentation and reduction. What about reconstruction?
Breast reconstruction rebuilds a breast after mastectomy. Done at the same time as the mastectomy, immediate reconstruction, or later, delayed reconstruction.
Lots of factors go into that decision.
Definitely. Very individual decision. We need to support our patients, help them weigh the pros and cons.
What are some techniques for breast reconstruction?
A few. Implants, similar to augmentation, or we can use tissue from the woman's own body, abdomen or back. Flat procedures.
Wow, they use tissue from neither part of the body to rebuild a breast.
Surgeons can do amazing things these days.
So whether they use implants or their own tissue, recovery takes time.
Oh yeah. Recovery can be long. We need to be there for our patients.
What's important during that time?
Pain management is key. Watch for signs of infection, bleeding, fluid buildup. Teach them how to care for their incisions and drains. Help them get their strength and movement back.
Holistic approach.
Exactly. And each patient's recovery is different. We need to tailor their care, help them heal.
Okay, we covered a lot. From benign breast conditions to breast cancer and mammoplasty. A lot to take in.
It is. Don't worry about memorizing it all right now. Focus on the basics, develop your critical thinking skills, and know where to find good information.
Good point. What are some key takeaways?
Breast health is part of overall health. Be comfortable talking about breasts, assessing for problems, educating and supporting patients.
We need to advocate for our patients. Make sure they get the best care.
Absolutely. Before we finish up, I want to talk about patient education again. It's so important, especially for breast health.
Totally agree. What are some key points?
Breast self-awareness. Women of all ages need to know their breasts, what's normal for them. Then they can spot changes and tell their doctor. Monthly self-exams aren't the standard anymore, but it's still good to be aware of any changes. Lumps, skin changes, nipple discharge, any pain.
Know your body.
Yes. And regular screenings, especially mammograms. Mammograms can find breast cancer early when it's easier to treat. Encourage women to follow the screening guidelines.
What about lifestyle? Can women lower their risk?
Good question. There's no guarantee, but some things can help. Healthy weight, regular exercise, limit alcohol, don't smoke. We can encourage patients to do these things.
Give them the tools to take care of themselves.
Exactly. We're here to support them.
Okay, so self-awareness, screenings, healthy lifestyle.
Yes, and you as nurses are so important. You're the educators, the advocates. You can make a real difference.
It is a privilege.
It
This
is.
deep dive has been amazing. So much valuable info for nursing students.
I agree. It's been great.
Thanks for being here. And to our listeners, thanks for hanging in there with us. We covered a lot. But that's what a deep dive is all about, right?
Absolutely. The more we know about breast disorders, the better we can care for our patients.
Couldn't have said it better myself. Before we wrap up, I want to leave you with something to think about, something to keep you learning. We talked about early detection and screenings. But what if we could go even further? What if we could find out who's at highest risk before they even get cancer? That's where genetic testing comes in.
It's a fascinating field, changing all the time. Huge implications for prevention.
Right. With genetic testing, we can find people with gene mutations, the ones that really increase their risk of breast cancer. This opens up so many possibilities. Personalized risk assessment, tailored prevention.
Mind-blowing. We could find those at highest risk, offer them more intensive screening, or even preventative measures, like chemo prevention or prophylactic surgery.
It's incredible. So here's my challenge to you. Look into genetic testing and breast cancer risk. The different genes, the criteria for testing, the implications for counseling and patient care.
Great way to keep learning. And this is just the beginning. Breast health is constantly evolving, new research all the time, so never stop learning, never stop asking questions, and never stop being an advocate.
Well said. This has been a great journey through the world of breast disorders. I hope you feel energized, ready to learn more. Until next time, keep those minds curious, those hearts compassionate, and those nursing skills sharp.
Thanks for joining us on The Deep Dive.